I want to give you a little personal background history and how I got interested in this issue, and make a few declarations about myself and convictions. I really started on the question of rationing when I was asked to serve on a panel of the Office of Technology Assessment in 1985, a government panel whose job it was to assess not just medical technology, but all sorts of technologies. And I was asked to serve on a panel to look at the impact of new technologies on the future of the Medicare program. A topic I had given no thought to whatever, wondered why they even asked me. In any case, I served on the panel, and I became persuaded at that time that the constant entrance of new technologies into the healthcare system was in fact going to create enormous problems for Medicare. And it was going to do so in great part because ironically, because those medicines were going to keep people alive for a longer and longer period of time, but not necessarily cure them. And one basic problem these days is we have great dominance in cost-wise of chronic illness, and most of them are handled by very expensive new technologies or intensive use of old technologies. So much of what we were talking about back in 1985, at that time it seemed a kind of theoretical discussion, even though the trustees of Medicare were saying the program was eventually going to run out of money, and given the increase in the number of elderly. As I got interested in that over the years, followed that debate over the years, one thing became pretty clear, that much the way we're talking about things now was the way we were talking about it in those days. Remarkably small change in public opinion. The trustees have changed because of the health reform bill. They've changed their projections about when Medicare may run out of money from 8 years to 17 years, depending on how the whole reform bill plays itself out. But the interesting thing is, so many of the issues were fundamentally raised then, and the only difference is they've just become more intense of late. Now, I might also say that my interest in this is, as the issue in later days become very politicized, the whole question of rationing and limits. That was, and I thought at the time, well, of course, if Medicare is going to run into huge problems, we'll not be able to give the elderly everything they want. And as many policy analysts said, to save Medicare, we'll either have to double taxation or cut benefits in half, or some noxious combination of both. And that was a very constant refrain over the years. In short, this was an issue that really, to save Medicare, was going to take require some very drastic changes in our thinking about the entire program. But nonetheless, we haven't changed much in our thinking. And as I will try to point out, so many of the problems that were identified earlier are simply here, and they've remained much the same. The question in my mind, though, over the years has been, particularly as I watch the health reform debate, is why is it so hard to talk about these matters of rationing and setting limits? There seems to be an political allergy, which I'll try to make some sense of if I can, toward having such talk. And there are so many things working against talking about it publicly that we really don't have a good conversation going. The public is badly misinformed about many of these issues. It's very interesting. A public opinion survey showed that 1/3 of the American elderly population believes that Sarah Palin was right, there are death panels. Well, that's simply false, but that's the way people believe, and it's very striking about the problem of how do you even get education going in this country. So I suppose the title of my talk might be, how can we get people to talk about what they don't want to think about? Because that seems to be the situation. I want to look at really deal with four questions in this talk. First, why is there a problem with rising healthcare costs? And what are its causes? Second, why has there been a long-standing resistance in this country, unlike most other developed countries, to taking decisive action to control cost, and in particular to set limits to expenditures and to ration care? Third, what forms can rationing take, and how can it be implemented? And fourth, what can be done to persuade the public and politicians to face up to it more squarely and forthrightly? Now, I will spend most of my time really talking about the Medicare program, because not only is Medicare the most monster entitlement program, being obviously very important in the healthcare system as a whole, because Medicare affects the rest of the healthcare system and is in turn affected by the rest of the healthcare system. But also when we look at the fairly recent debate on the healthcare deficit problem, Medicare and Social Security and Medicaid turn out to be the main monsters to be dealt with, but particularly Medicare. So Medicare is important in itself for its impact on cost and its impact obviously on the elderly, but also in terms of the overall healthcare system and the overall American economy. Now that gives you, I'll say very little about it, just to give you some figures to remind you. Right now, there are roughly 46 million people over the age of 65 in this country. In 20 years, that number will be close to 80 million. Most importantly, what economists call the dependency ratio, or demographers talk about the dependency ratio, that is the number of working people in relationship to the number of retired people. Right now, it's 3.7 workers for every retired person, and that's going to decline to 2.9. This means there are going to be fewer younger people proportionally who will pay taxes to support a rapidly growing number of older people. Right now we spend about $500 billion a year on Medicare, expected in 10 years that it will double. Now, I'm not going to discuss the impact of the health reform program. I think at this point you can find any opinion you want on its likely future. Those who say, yes, it's going to save huge amounts of money on the optimist side, usually the liberal side, and the conservative side, say, no, it's wrong. It's going to cost billions of dollars, right? And every possibility in between. So we really don't know how that's going to play out. The Republicans want to kill the Obamacare, as they call it. Democrats are not sure what to do about all of that. The public is surely confused, ambivalent. So I'm going to leave that aside. But let's, in any case, the aim of the health care reform bill, and I think what you might call the gold standard in health care, is that the health care now increases at around the rate of 6 to 7% a year in cost. And that is considered unsustainable in the long run. The ideal is to get it down to around 2 or 3%, which is where the increase in our annual gross domestic product. Right now, we have our gross domestic product going up like this, but our health care costs going up like that. And eventually, we've got to find some way to plateau and get them aligned. We're a long way from doing that right now. The question is, why do we have these problems in the first place with cost? Well, I think I would say that I would distinguish between basic cost and sort of intensifying factors. The basic reasons are an aging population, expensive new technologies and intensified use of old technologies, very high public expectations and demands on the healthcare system. Now, interestingly, it's a whole side story, but every healthcare system in the world is having the same problem, however they're organized. I've spent a lot of time in Europe over the past 20 years, and every country you go to, you'll hear it sounds like the debate here. It doesn't matter what their system is, whether it's single payer or social health insurance, a different kind. Sometimes they're turning to the market, sometimes toward more government. They all go back and forth. So I came to think that the fundamental problem here is there are some basic driving forces which have nothing to do with the organization or management of healthcare. The Europeans do much better in holding down their healthcare costs, but they all have problems as well. So the basic causes are the underlying aging technology and the combination. It's, I would say, the whole very expensive venture of modern medicine, which has turned out to be extraordinarily expensive. Now, then there, in the U.S., there are what I call intensifying factors. We have a dysfunctional healthcare system because of our strange mixture of the public and private. We have deep political disagreements, and we have, I think, a very clear lack of public understanding and a good, clear picture of what's actually going on. And that's not hard to understand because it's a very complicated system. Now, why has there been long-standing resistance to setting limits? Jacqueline, could you bring my water here, please? Good, thank you. This is dry desert air down here. Why has there been, second question, why has there been long-standing resistance to setting limits? and to having a serious public discussion. Well, I think a nice place to start was with the fact that when Medicare came into existence in 1965, Congress refused to allow it to take cost into consideration in provision of benefits. Only reasonable and necessary benefit care could be provided, but cost was off the table. And to this day, it remains the same. Jacqueline wrote a wonderful article about the history of that prohibition, and there has been no move whatever to do anything about that. Moreover, the new interim director, or at least the director of the Centers for Medicare and Medicaid, Donald Berwick, is probably going to lose his job because he has talked about rationing and the necessity, and he had an interim appointment by President Obama, but apparently the Republicans are going to shoot that down. So to this day, Medicare, that is off the table for them. Interestingly enough, of course, the private sector rations all the time. Anybody who has private insurance knows that they deny lots of claims. There are a lot of things they don't cover. You don't hear much about that. Nobody seems to fear what the private sector is doing in denying claims, but everybody gets rather upset when you talk about the government doing so. So in any case, there are an enormous number of disincentives not to talk about this issue. First of all, we have very well-paid physicians in this country, much more better paid than any other country. We have an enormously profitable medical industry, drugs and devices. We have a large sector of for-profit health hospitals, clinics, and the like. The healthcare system is an area of economic growth. It's one of the few areas during the recent recession that keeps adding jobs. So it's not losing, it's keep adding, which of course is, in one sense, is wonderful for the economy, but it's not the right direction for healthcare to be going. And finally, there is a widespread belief that ours is the best system, that we don't need to talk about this, it's really just doing fine. And as a matter of fact, probably 80% of people in this country are pretty well covered by insurance. So if you're reasonably affluent and you've got a good job with a reasonably large company, you're probably going to have pretty decent insurance. So those are some of the incentives. There's not much interest in cutting costs, in great part because somebody's cost is, as it's often said, one person's cost is somebody else's income, and that's very true in this case. And there's enormous political ambivalence. Conservatives are anti-government. They want no price controls, very generally, no interference with doctor-patient relationships and decisions, and it's very striking, politically speaking, how the Republicans have made a big fuss about the deficit and doing something about that, and yet at the same time they've only picked on the discretionary programs, of which the Department of Defense is one of them, and they're even have mixed feelings on that, but will not go near Social Security and Medicare, at least so far. So you find among conservatives a wariness of taking the issues on. But it's also the same, interestingly, among liberal policy analysts. What I found in this issue, there are some economists, for instance, who say it doesn't matter how much we spend on health care. I mean, what's better than keeping people alive and keeping them well? It's a great thing. The cost should be irrelevant. That's a small minority, but there's some rather prestigious people who've said that. Then there's a constant worry about harming the quality of health care. Everybody says, yes, of course we need rationing. We've got to set limits, but not if it affects the quality of health care. Well, my conclusion for a long time has been, of course it's going to reflect the quality of health care, particularly it may not in fact hurt their health care, but it will be their perception of health care of a society which has gotten used to the latest and the best. Finally, there are threats to innovation. The medical device and drug industry has been very adamant that they don't want any kind of rationing that would hurt innovation, by which they mean the creation of new drugs and sale of new devices. So what you have here is an ambivalence on, I think, on both the left and the right about this issue. And perhaps most striking over the years, and this has been persistently true since at least the 1980s, there is very little public support for any kind of cuts on Medicare. A recent survey by the Kaiser Family Foundation said that 68% of people surveyed said that budgetary problems could be solved without any reduction of benefits. The only option that the public seems willing to accept is higher taxation for wealthy people. Well, that's been true persistently over the years. No change there. So, and one reason you see why politicians are nervous about an issue where most people think they don't want cuts. In fact, they resist cuts and they're against taxes in general, unless it's rich people, which most of us are not. So you really have a situation that's trouble for politicians from the right or the left in dealing with this. So legislators know they're playing with fire. They have no solid public support for rationing or cutting of benefits, and this shows. Now, let me go to my third question. What forms can rationing take, and how can it be implemented? Well, I think, I'll talk at two levels. There's the macro solution level, and this is what the European countries do. They basically control healthcare costs by heavy government regulation, price controls on drugs and insurance premiums, control of new and old technologies, negotiated pay for healthcare workers, and I think fundamentally also somewhat lower public expectations about what healthcare ought to be delivering. But in general, those systems, as I mentioned earlier, work pretty well, but they're in trouble too. It's just that they're lagging a little behind us because they control costs better, but that's how they do it. Now, at the macro level, of course, we have conservatives in this country whose solution would not be universal health care as in Europe, but basically either some kind of a voucher plan, giving people a certain amount of money and letting them buy, giving people more choice, and having more competition among providers. That's never really been tried effectively in this country. Whether it work or not is anybody's guess. Now, when we talk at the micro level of rationing, I distinguish among three levels here. What I call direct rationing. That is to say, a government agency or a private insurer says basically we will not pay for such and such a treatment or such and such a drug. Just using their particular power, whether in the private sector or government, a flat refusal to pay for things they consider either not worth the money or too costly or some bit of both. That's direct rationing. That's what probably most people think. Now, there's something I call indirect rationing, with which we're all familiar, and I put in that category co-payments, deductibles, and co-insurance. That is to say, what we're seeing in the private sector and Medicare both is there's significant increase in co-payments and deductibles, and increasingly what's happened is you have health insurance costs in the private sector is going up at the same time as the companies are imposing more tax, more deductibles and co-payments. And I think that's probably the main way we have started to control cost. There was a wonderful quotation by a losing Yale football coach once, which he said the trick is to keep the alumni sullen but not mutinous. And I think in the case of the co-payments and deductibles, that's where we have really begun to control, one way to control costs. And it doesn't get the sort of outrage that the idea of direct does, but it's very effective, and I think we'll see much more of that. Finally, there's the covert rationing. And I suppose the best example of that would have been Great Britain during the 50s through the early 70s maybe, where in effect physicians understood, without it being written down anywhere, that you simply had to give patients very expensive treatments. There was an unwritten rule that after 55, no one got dialysis or expensive forms of open heart surgery. And I once tried to say, well, where are the rules about that? There aren't any rules. The point is, if you, in those days probably still, if you had to work with an annual budget, which they did, area by area, it was pretty clear that if you spent a lot of money on these very expensive technology, you were going to not have money for anything else. So it was just understood you've got to cut out the expensive stuff and to preserve the whole system. And basically, patients were not told it was rationing. They just said, there's nothing, sorry, yes, we see your kidneys are failing, but there's nothing we can do for you. That was a flat lie, but nonetheless, I think maybe our other speaker can talk about that. But at least for a long time, The National Health Service got away with that, but I think eventually the public caught up with them. But I'm told that it still goes on in some subtle ways. Now, my own guess, having looked at those three methods, is the co-payments and deductibles is probably the way we will go. I think direct rationing is would be the fair way. Do it with open commissions and committees making decisions. But the question is whether Americans would ever tolerate that. Even in the UK, which as an agency which tries to assess technology, it does that to some extent, but it gets itself often in trouble with the press. People get enraged. They want to deny somebody a particular treatment. People go to the press, or the press hears about it and raises a big fuss, and sometimes the National Health Service backs down because of the fuss. And I think in this country, any open rationing would create an enormous fuss. But I think that would probably be the only fair way to do things. But that may not happen. Now, let me conclude by suggesting some ways to deal with the problem. Can we get the public to talk about it? Well, it's going to be very hard. Can we look to political leadership to talk about it? Well, political leaders often, once in a while, ignore public opinion surveys. But when you have such low support for any cut in benefits, it really gets tough. When the support is down at the level of 20-25%, only like 20-25% of people are in favor of any cuts in the Medicare program. Well, that's very hard for a politician, and it doesn't seem to matter whether their political leanings are left and right or right. Now, I think one of the problems is that Republicans have to stop trying to have it both ways. Republicans, I'm a dedicated reader of the Wall Street Journal. It's not my politics, but I read it just to keep abreast of what the other side is saying. And it's striking how the Wall Street Journal is the great one pressing for deficit reduction. We've got to bring down these expensive government programs. At the same time, they endlessly rail against any and all proposed methods of cutting benefits. They attacked the idea of comparative effectiveness research very sharply. They attacked the idea of an independent payment commission, which is meant to gradually pay less for Medicare coverage. So there's a funny ambivalence within Republican ranks of being, on the one hand, that this is just awful the way we have all these expensive government programs, but in fact they're fearful of going near the ones that really count. They may have to come around. Some Tea Party people are pushing them to go in that direction, but so far, but it's striking this kind of imbalance. So you have in the Wall Street Journal, the op-ed pieces on the one hand, my God, we got to get rid of all this heavy hand of government, and on the other hand, but any effort to actually do something about it often gets shot at the same time. I think we have to really persuade Democrats in turn that we have a healthcare system which is inherently unsustainable, that people will have to give up things they want. And I think in particular, we'll probably have to raise taxes. There are an awful lot of people that can afford to pay more taxes, people like myself, in pretty upper middle range, and certainly a lot of wealthy people. And the idea that right now that raising taxes is off the table makes no sense at all, given the pressures. And of course, as I say, the public wants rich people's taxes raised, but not their own. But I think everybody, if they really want Medicare, they will have to do both some tax increase and some cutting of benefits at the same time. Now, I'll end on a final note. My own belief, having looked at other healthcare systems, is our basic problem with control of healthcare costs is we have a model of medicine in our head which is progress-driven. It is a belief that medical progress should always go on, that we should not consider cost as we work on cures of disease, that somehow cost is something that is very un-American to even discuss in public. But most fundamentally, because we believe medicine should always be getting better, should be saving more lives and giving us better health. But the point is that open-ended model of progress, I think, is doomed to stop. We certainly find with the chronic disease, which is 60% of healthcare costs, can be traced to about 20% of people, and that's people with chronic disease, multi-organ failure, and the like, primarily the elderly. That's where the highest costs are, and that is, of course, where the most intensive use of technology is to be found. But it's also where what we're finding is we can't cure these terrible diseases. All we can do is so far find very expensive ways of keeping people alive with these diseases. Well, that's an unsustainable route. So we've got to rethink. No time to enter into this. We have to think the problem of death. What's the place of death and health and death in the healthcare system? What should we do for the elderly? My own belief is we should help young people become old people, but not help old people become indefinitely older. There has to be a limit there. We have to ask some very fundamental questions about the entire medical enterprise, and this not just about organizing it better. With that, I will stop and let others have their say. Thank you.